Here's David going through his paces less than 2 weeks after having both his knee joints replaced. You're going to be impressed. Watch.
So Mr. Clip,
Yes.
you had your surgery 13 days ago. So you had your surgery on a Tuesday, both your knees done. You came out on a Friday.
Right.
Therapy started next day, or nursing came out the next day.
Yes.
You've had 4 therapy sessions, or this is the 4th one.
Yes.
And you're scheduled for outpatient next week.
Yes.
And you haven't got your staples out yet.
I get them out this Thursday.
Okay.
This Thursday.
Okay.
Day after New Year's.
So what do you think?
It's great. I mean, if I was going to do it, I'm glad I got both of them done instead of doing the one and then going back in. I can't see where the pain would have been any less having one. Just to go through it one time is a lot better than going through it twice.
Okay.
Yeah.
Well, let's see how far you can bend your knee. How about if you lay back here?
Okay.
And let's see how you do.
All right.
Okay. So, Mr. Clip, let's go ahead and see what you can do on your right leg.
Okay.
And pull it in and heel in towards your bottom. I had measured this a minute ago, and it was about 115 degrees, which is great, which is actually a little better than what we might have expected at this point. And go ahead and straighten it out. And drive that knee all the way down, lock it out straight. And how about your other knee, your left knee?
What do you want me to do? Pull it up?
Yep, pull it up again just so they can see how far you can bend that one. Pull it in as far as you can. Pull that heel in towards your bottom. Bend, 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 bend. Keep breathing. It's a healthy habit. Good stuff. And straighten it out. Good. So that side we measured and it was about 103 degrees on that. So he's doing great. He's 13 days out. Again, he'll get his stapled out in a few days.
He hasn't even got his skin staples out yet, and he's already walking down the street without a cane. Fantastic. Surgical rehabilitation is the restoration of function following surgery or an injury by therapy and education. Surgical prehabilitation is rehab that begins before the surgery. So when Dr. Steinberg scheduled bilateral knee replacements for David, he let David's PT, John Baker, know the date and the nature of the surgery. John then visited David at home. He assessed the house, giving advice about stairs, rails, rugs and lighting. He made sure that his wife and he both knew what to expect so they could have confidence going into the surgery. Most importantly, David was given exercises to improve flexibility, balance and strength. Then, John's final visit occurred a few days before surgery. I asked him what is done during that final pre-op visit.
Well, right before surgery, you want to make sure he's ready to go in. One of those things that we want to review is that he's done a surgical wash. We want to make sure that they understand the infection control aspects so that we can mitigate or lower his potential for infection. There's also the risk that we want to make sure his lungs are open up, so we review that he's going to be using a spirometer and the importance of that. We also talk about that he's going to be getting some sort of way of thinning his blood. And so there's a variety of ways that the surgeon can choose, so we review that. We also talk about TED stockings that he's going to use. We also talk about as far as ankle pumps and certain circulation exercises that are important for him to do.
So that's the immediate pre-op. So do these make a difference, all these, like the surgical wash, does that reduce infection rates? How much by?
It definitely reduces rates. There are some studies that show some institutions have decreased their infection rate almost by half. Where you're dealing with maybe a surgical center or a hospital that will say have an infection rate of 5%, and they cut it down to 2.5%. I think that's phenomenal. It's certainly one of the things to look for because it's a disaster to have an infection in a joint replacement.
Right, because when we've got a implant like this that gets infected, it's
typically has to be removed. And then you're looking at a patient that will have what's called a cement spacer put in that has antibiotics in it. And then it's usually a minimum of 6 to 8 weeks to be able to come back in and put a new knee in. So it's not a fun process for the surgeon or, more importantly, the patient.
So that surgical wash helps, and then the spirometry, presumably the anaesthetist is pretty happy when his patient comes in with his lungs in good shape.
Oh, definitely.
Yeah. And it saves the physical therapist afterwards trying to clear a chesty patient too.
Absolutely.
So how many patients have you put through prehab now?
In this particular program, we've done about 120.
And what are the outcomes looking like? Does it look like something that's definitely worth investing in?
Oh, no question. It's been wonderful. Actually, of the 120, we've only had one individual go back into the hospital in the first 30 days. If you were to look at those statistics, those are awesome. Personally, they're probably unsustainable because they're so good, but it's awesome that we've had 120 people go through it and only one person has gone back in. And they only stayed in for a very short period of time and then came back out.
So that reflects really well on your surgical management, doesn't it?
It certainly helps. I wish I could say that all 120 were my patients. I think a lot of them are, but definitely it helps. I mean, getting people up quicker, using some of the things John had mentioned, the TED hose, I think is key to help prevent these post-op complications.
So why hasn't this project yet? We've been doing joint replacements for decades.
True.
What's driving it now? What's happened? What's changed?
Lots of different things. I mean, patients want instant gratification. They want to get up, get moving quicker. We're doing joint replacements in younger and younger patients these days.
That's not so good.
Correct, but it's the demands. The baby boomers are coming in. I mean, there were almost 700,000 knee replacements alone, 700,000 knee replacements performed in the United States last year. That number is only going to increase. And you know, the stresses on the healthcare system in general, outcomes are being measured very closely and scrutinized in this country. And all of this plays into that. So we need to have good outcomes, and that's how surgeons are going to be graded, how hospitals are going to be graded, and more importantly, have good outcomes so patients have, hopefully, you know, improved quality of life and, you know, do not have these disastrous complications after surgery.
That you put one implant in and it stays there, it doesn't get infected. And
That's the idea.
And you're back on your feet. Wow.
I think as Dr. Steinberg was saying, you know, outcome data is all the more important now. In the old system that is going away, a fee-for-service, where you get paid for what you do, that has different things that are pushing the system down the road. In this new healthcare system that's coming down the road, where basically you're looking at outcome data in the most cost-effective way, combining those together, what we call value. That's where healthcare is heading. Mm-hmm. It's who's going to provide better value, meaning who can give me great outcomes, return me to independent living, knock down my pain level, restore me to getting back to what I want to do in the most cost-effective way, or value. And that's where things are heading now.
So we're talking cost. Does this cost more for a patient, this doing the prehab and having the surgery?
Actually, it doesn't. It costs less. Now, most of the studies are not from the United States, of course. We're a fee-for-service setup. But over in Europe, where they have different healthcare systems, socialized medicine, they're more in tune historically over time in looking at that. And so the data is clear over there. And it's not just limited to orthopedics.
Mm-hmm. So prehab is happening in other arenas now?
Absolutely. And in fact, some of the latest stuff has to do with cancer treatments.
So
if somebody is going
chemo or pre-chemotherapy or pre-surgery?
Both. If you're going in for chemotherapy and you want to get stronger, you find that when you have chemotherapy, your system goes down here fairly quickly. And so if you're stronger beforehand, your outcomes are better. If you're going in for throat or neck surgery and you're going to have 2 months of swallowing exercises, that will affect your outcome. If you've got prostate cancer and you have 2 months that are strengthening your abdominals and your pelvic cavity, that is going to improve your bladder control. If you have lung cancer and you're going to have surgery, it actually improves as far as your oxygen saturation and your ability to expectorate, to cough, the ability to actually become independent and get off oxygen. All these predictors are improved with prehab beforehand.
Sounds like it's definitely the way to go. And how's David doing?
David's doing tremendous. David is a great patient, but a very motivated individual. He took the prehab to heart, and it definitely paid off for him. But no, he's aspiring to be on the golf course here once the weather breaks. So.
Excellent. Thank you so much, both of you, for coming on the show. We've run out of time, but it's been very enlightening.
Thank you.